Hi, everyone. I want to welcome you to our Neolite Cares educational session. We do have a global audience here with us today, so we are so excited to be able to present this information to you guys. We've done this in the past and we'll be doing it in the future. So we are just really excited to have Edyta with us today and talk about ROP screening, or retinopathy of prematurity screening, and nurse-led programs. So for those of you who are joining us for the first time, Neolite Cares is a program that supports educational resources for users of all Neolite equipment. A little background for CARES: it stands for Continuing Advancements and Resources and Education Support, and that's exactly what we do. We have a plethora of information, including policies and procedures. We have competencies, skills checklists, quick guides, manuals, really just anything that you would need to be successful with using equipment that we provide here at Neolite. We have that all on a single platform at theneolite.com, and that's theneolite.com. If you navigate to our education tab, you're going to find e-seminars like what we're recording today. You're going to find system-specific information for the systems that you have in your unit. You'll be able to find updated information as we learn more about what's going on in the market. We continuously look to provide more information for those nurses and staff members who may be utilizing our equipment in the field. So we're really excited to bring that to you and kind of use that platform to present information like what we have today. A few housekeeping items before we get started. We do have everyone on mute just to minimize background noise. We know some people join us in different time zones, so they get to be at home with their families, or some people are listening from break rooms. So we want to make sure that we have a good educational platform with minimal noise. Everyone's camera is also turned off so that we don't have any distractions from things happening in the background. As we move into the presentation, Edyta and I will also turn off our cameras. That way we can really focus on the information being presented. We don't have to worry about moving cameras back and forth. You'll be able to see the screen and see the information very clearly. There's also the opportunity to pose questions throughout the presentation. If you have questions, feel free to submit them. We'll also open the platform for people to submit questions at the end of the presentation, and that's when we'll answer as many questions as we can get to. If for some reason we don't get to your question, you're more than welcome to reach out to any of our clinical team. You can also find support on theneolite.com, and we'll make sure that we get back with you. We can share documentation, we can talk about educational opportunities, anything that we can do to help your system and help with the use of equipment, we're happy to help with. So without taking any more of anyone's time, I would love to do an introduction for Edyta, and then we'll get started with our presentation. So I've known Edyta for many years. She brings 12 years of experience as a NICU RN and later worked as an ROP Clinical Manager and Coordinator Specialist. She pioneered an enormous nurse-driven program. Her clinical nurse specialist and ophthalmologist worked so closely with her, covering 4 high-volume level 3 NICUs. Edyta trained a team of 14 RNs to screen for ROP using a retinal imaging system, and they were so successful with those programs. They screened over 500 patients annually for ROP with 100% outpatient follow-up rate for all patients, including their high-risk patients as well. So Edyta comes today with a beautiful program built, and she's going to teach us how we can take those successes into building other programs in units. So Edyta, I'm going to go ahead and share my screen, and then we can turn our cameras off and go ahead and get started with your presentation.
Thank you. My camera doesn't want to turn off here. Let's see.
We just want to keep you on the whole time.
I know.
Let me see here. If I'm going to take this, I might be able to turn it for you. Let me see here. There we go.
Here, perfect. Okay, excellent. Well, thank you so much, Candace, for that wonderful introduction. And thank you all for being here today. I'm so excited to share some of my knowledge. As Candace had mentioned, I was fortunate enough to establish a very large nurse-driven ROP screening program, and we were so successful, and it was such a wonderful and incredible experience. And I just want to share some of the things that I took away from that, and hopefully that you can implement into programs of your own. So without further ado, let's get into the webinar. And it is entitled Understanding the Numerous Benefits of a Nurse-Led Retinopathy of Prematurity, or ROP Screening Program. So let's get started. So here are our objectives for today. We're going to briefly go over the types of ROP screening programs. I know a lot of you are familiar with this already. And then the majority of our webinar is going to be focused on the benefits of a nurse-led ROP screening program. And for these benefits, I've broken them down into 3 segments. The first part is the nursing perspective, then we're going to go into the patient perspective, and then also into the unit perspective. Then after we've got understanding of the benefits, we're going to go into how do you select and create your ROP screening team. And then we're going to go into how to implement your new program, and then how to evaluate for success. Okay, so the 2 types of retinopathy of prematurity screening programs are right here. So the first one is your traditional binocular indirect ophthalmoscopy. And that's where the ophthalmologist comes into the unit. He physically has to come into the unit and wears his binocular indirect headgear and screens the patients. When he is ready to document his results, he hand draws the images that he sees from the back of the eye, the retina, onto a document, and that's scanned into the electronic medical record. So again, this is very dependent upon his availability to come into the unit to physically screen your patients. The other type of ROP screening program is retinal fundus imaging, so ROP screening with a camera. And this is where we take photos of the retina. So rather than a drawing, you're having actual photos of that patient's retina, the back of the eye. And this can be performed by numerous different staff members. So it can be performed by nursing staff, by the physician's assistant. It can be done by the neonatal nurse practitioners, or by the ophthalmologist. And what's wonderful about this system is that you can easily compare images from week to week, and it's much more clear than a drawing of the documentation of the eye. And it also allows for more flexibility because you have way more people that are capable of doing the screening and documenting appropriately. So why choose a nurse-led ROP screening program? Well, there's lots of reasons, but let's look at some of the benefits. So as I said before, I've broken down the benefits into 3 parts, which is the nursing perspective, the patient perspective, and the unit perspective. And we're going to dive deep into each one of these. So first, let's start with the nursing perspective. So here are some of the benefits from the nursing perspective. And there are so many, but these are some of the main ones that stick out in my mind. So the first one is nurse autonomy, then flexibility, an increase in the pride of care that's given to these patients. The nurses are able to gain a new skill set. It's an opportunity for growth. They get control of the patient experience. They provide consistency of care, and there is ample time for teamwork. So let's look at each of these individually. So one of the first benefits is nurse autonomy. What's wonderful about this one is that it gives the nurses really the freedom to work both independently and as a team. They can make decisions on how best to obtain those patient images, which is so amazing because nurses know these babies better than anyone else. And so they can really make adjustments to fit the patient's situation and make it most comfortable and get the best images possible for those babies. And because of that, they're able to embrace and implement their patient care knowledge that they know from taking care of these babies in the NICU during their exam. And it also gives them the ability to drive the entire program, from scheduling to doing the exams to working closely with the ophthalmologist to parent education and also scheduling treatment. They're involved in every facet of the program. The next benefit is flexibility. What's wonderful about having a camera to do ROP screenings screening exams is that there really is just so much flexibility in when these exams can be done. Rather than having an ophthalmologist being very limited in time to coming in to see your entire unit of babies, you can really split the exams up. You can do them during day shift. You can do them during night shift. And not only that, but you can decide what time in those shifts works best for the patients, for the nurse screeners, and for the unit as a whole. Maybe 4 o'clock in the morning is the best time for you to do your screenings because there are no families on the unit and it's just a quieter time on the unit. It's really up to the screening RNs and the unit and the ophthalmologist to really work together and make it flexible and really make it work for them. The other key player that it's flexible for is the ophthalmologist. So the ophthalmologist can identify the best day of the week that's best for them to read the exams. And then if they need more exams on a baby because the baby is more critical and the disease is progressing more rapidly, they're able to ask their ROP screening RNs to go in and do additional exams rather than having to stop their entire day to come in to see one patient. They can have the RN screening nurses that are often there already working shift, or it's just easier for them to come in. They don't have a whole clinic that they're taking care of to come in and do those more frequent exams as needed. Also, it provides flexibility with the patient. So this is totally patient need dependent. So you can really modify the times that the exams are done. If the parents are visiting there, you can go a different time if the parents don't want to be there during the exam. If they have physical care times or assessment times, which most babies do, they're on an every 3 or 4 hour schedule. You can schedule their exam times for those hands-on care times. And then you can also do it before and after feedings. Some babies have problems with reflux, and so it's better for them to do the exam before their feedings. But some, you're really working on that endurance for feedings. And so maybe you want to do the exam after their feeding is complete. It's totally up to you and for the bedside nurse and for the patient needs that are present. And you can also, one of the other amazing features is that you can schedule around procedures. So rather than the ophthalmologist coming in at 9 a.m. and getting all of the ROP screening done himself, if that baby has an MRI scheduled that day for 9 a.m., they can do it prior to that or after that. Or if the baby has to go off the unit for another diagnostic test, it's really way more flexible than having the ophthalmologist just come in to do the binocular indirect exams. So another benefit from the nursing side is that it really does increase their pride of care. They have more control over these exams being done, and the more they do it, the more their confidence is going to grow. The quality of the exam is going to increase. The quality of the images is going to increase, and they will be motivated to do their best work. Additionally, they'll have the benefit of building relationships, not only with the other nurses on the unit, because they're going to be helping them as their second pair of hands for these exams, but also with the ophthalmologist, the neonatologist, the entire care team, and of course, the family. Another nurse benefit is that they're able to gain a new skill set. So this is really exciting for a lot of nurses because a lot of nurses get excited about the idea of helping with new things, being involved in something bigger than just providing care. Although providing care to these babies, nursing care is so important, it's often really intriguing to be part of something bigger, right? And so if you do purchase a camera screening system, you'll obtain a false patient head with a false eye, and we really encourage the nurses to practice as much as they can with this false head and false eye to really gain a sense of comfort with the equipment and with the software, and just to understand how exams are done before they place that on a patient. It's something that they're going to need to learn to do to maintain their proficiency, and that's totally unit dependent, depending on how many exams you have and what you feel is adequate to maintain proficiency. It's something that they can add to their resume, and they just become a more valuable part of the unit. And like I said, they feel part of a bigger team as a unit. this kind of piggybacks off of that. But another benefit is that it is an opportunity for growth. So with this new skill set that this nurse has obtained, they become more marketable and much more valuable to the unit, right? And so they can also add this for any career ladder advancements or any other leadership opportunities that may come along the road. It's something that they can use to maintain their competency, and it is a new learning opportunity. The more they understand the disease process of ROP, the better it's going to be for the entire program, and they might even decide that they want to continue getting continuing education credits, excuse me, by attending conferences and other educational things like this webinar to further progress their skills, and everyone will benefit from that. Also, the more involvement they have in the unit and the patient care, the more, again, they're going to have more pride in the care, and you're just going to have an overall better patient and family experience. The next benefit is the ability to control the patient experience. So again, as I had mentioned, and I'll say this several times during this presentation, but nobody knows these babies better than the NICU nurses. So they're able to read the baby's stress cues, and they can pace the exam however it's tolerated by the patient. If they need to go a little bit faster, if they need to slow down, if they need to stop in between eyes and come back and do the next eye, they can absolutely do that. So again, they can reschedule as needed. It's based on patient tolerance, and then they can also work with the family. So if the family wants to be there to watch, they can schedule it for that time. If the family would prefer not to watch, that's okay too. And they can schedule it for a time that's appropriate for that family. They can also provide appropriate comfort measures. Again, they know these babies. They can provide containment, a pacifier. If a baby is critically ill and requires pain medication prior to the procedure, they can advocate for that. And they, again, can schedule to fit it in for the patient needs. Another benefit is that it provides consistency of care. So this, you'll see this throughout all three areas. But what's wonderful about having a small RN screening team is that they become very familiar with those ROP patients. And so similar to the primary care nurse model, wherein nurses care for babies, a primary baby when they are on shift, they really get to know the ins and outs of that baby, the family dynamics, and all the intricacies that are involved with the care of that baby. It's so similar in ROP screening with nurse screeners. So they get really familiar with those patients. And then you're also just going to have a consistent presence of the screening team. And because they're going to be there during the consistent date and time, maybe it's every Tuesday at 9 a.m. that they start, the family and everyone will be aware that that's when the baby gets their exam. Typically, it also builds trust within the family because they're seeing a familiar face. And like I said before, they're going to really learn and understand those patient cues. And last but not least is a benefit from the nursing perspective is teamwork. So again, your ROP screening team is going to be made up primarily of these at least 3 people. So you're going to have your ROP coordinator, your screening RNs, and that's totally unit dependent, size dependent, however many you might need to provide adequate coverage. And then your ophthalmologist. And those are going to be the people in your screening team that are going to be in constant communication, not only with each other, but also with the entire care team so that they can let the whole care team know what's going on with the patient. And of course, discharge planning begins upon admission. And so it's just another part of that discharge process for everyone to be on the same page. And of course, it's just wonderful to be a part of something bigger. So the next set of benefits that we're going to look at are benefits from the patient perspective. And here they are. So again, consistency, the flexibility to meet the patient care needs, decreased disruption of care, promoting a family-centered care, minimizing patient discomfort, increased parent understanding, increased compliance post-discharge, and decreased patient transfer. So let's look at these individually here. So the first one is consistency, and I kind of mentioned this one before, but Just like with the primary care nursing model, you're going to have your primary ROPs, RN screening team that's going to be so familiar with that baby, with that family, with all the circumstances surrounding that patient. Again, the consistent day and times of the exam, building trust with the family, seeing them week after week after week, the same faces. The more the family sees you, they're going to build a relationship with you, and they're going to be more comfortable asking those questions that maybe they'd be too shy or uncertain of themselves to ask of a stranger that they've never seen before. But when they see that familiar face, they're going to build a comfort level with you and be able to ask those questions. And the better understanding that they have, the more education that they have regarding ROP and all the risks about it, it's just going to be a better all-around scenario for everyone. They're going to be more involved in their baby's care, and it's just going to spiral, and it's going to be wonderful. And again, the consistency allows them to learn and understand patient cues, and the baby will kind of learn to kind of know what to expect when the exams are coming. And the screening team will learn what's best for that baby. So the next, from a patient perspective, the next benefit is a flexibility to meet the patient care needs. Again, the nurse can adjust the pace. If the baby's not tolerating it, they can go faster, they can go slower, they can reschedule for a whole nother day if they need to. They can provide containment and pain control measures as needed. They can reschedule based on the patient and condition, or if they're having any procedures that day, they can make sure that nothing overlaps and that the baby doesn't miss an exam, but that it's done in an appropriate time period and that all the care that the baby needs to receive that day is done. Also, another key thing is that it does allow for family bonding. If the family is there for feeding, they can reschedule, they can come back. If the family is there for skin to skin, maybe it only works for them to come at noon every day to do skin to skin for their baby. They can understand that and not schedule an exam during that time so that the caregivers can have that uninterrupted skin to skin family time, bonding time. If the siblings come in, all that good stuff. So it's really flexible in doing whatever that baby needs for that day. Another patient benefit is that it decreases the disruption of care. So again, schedule it when it's best for the patient, whether that's day shift or night shift, and where in those shifts that falls. And then because we're trying to get in there, usually the goal is to get in there with those hands-on times. It really allows for uninterrupted sleep times between those sessions, which promotes growth, digestion, and respiratory stability, which is what the baby needs to be able to go home. And that's always our ultimate goal, right? Is to get those babies home. It also promotes family-centered care. You're going to really advocate for that uninterrupted family time that we just discussed. And the family can tell you whether they want to be there for the exams or if they'd rather not. And either way is totally fine. But it just gives them another way of having control over their baby being in the NICU, which can be such a difficult experience, but it just fosters another level of parent involvement and understanding and what's going on with their specific infant. So anytime can do that and make the parents more of an advocate for their baby, you're setting them up for success. The next patient benefit is that we really can minimize patient discomfort rather than an ophthalmologist coming in and rushing through all the exams because he has to get back to his clinic or he has to get back into the OR to treat patients. The screeners are NICU RNs. They understand those patient cues. They can adjust the exam and the pace to fit the patient cues. And I think what's most important is that they can prepare the patient adequately and then finish up with the patient adequately so they can provide that containment, the swaddling, any kind of pain medication if they need it, sucrose if they're able to have it, a pacifier, proper positioning. You can get that second pair of hands, third, fourth, fifth pair of hands if you need to, depending on the patient's situation. If they're an older baby that's a little bit stronger and they need more firm containment, you can do that. If they're a very critically ill baby, maybe on high frequency ventilation, and you need more hands to manage all their lines and tubes because they are so critically ill, that's always an option too. So we're really doing it to maximize patient comfort and do it as quickly, of course, as we can, but also to have the baby tolerate the exam as well as possible. And then one of the other final pieces that's so fantastic is that, again, because these screeners are NICU nurses, they tuck those babies in after the exam is complete, and it really decreases the bedside RN workload. So rather than the baby just being open and unswaddled and uncontained, and somebody walking by and it's very quite obvious that someone has been in that bed examining that baby, NICU nurses are fantastic at tucking those babies in and really letting them settle before they move on to that next patient, because again, they have more time to do so. So this is a really important patient benefit, and you're going to increase parent understanding. So again, with all these things that we've kind of talked about, the more consistent you have the same group of people coming to screen the same babies, you're going to build trust between not only the screener and the ophthalmologist, but also with the family, and you're going to build a relationship that's going to be ongoing. It's much better to provide parent education for their infant's disease process. Parents aren't as squeamish or as averse to hearing about it. I find that they are really interested in at least understanding what's going on and why you're taking these pictures of their baby's eyes. And what's wonderful about using a camera system is that you get clear photos and you can compare them from week to week, which is much better for a parent to understand what's going on than hand-drawn drawings, which, although they do show progression of disease, are a little bit cumbersome and are a little bit confusing for someone who's not trained in looking at these. But a picture is clear and a picture is concise, and a picture can very clearly show you what's going on, and you can compare from week to week. And what's great about that is that if their baby does require some sort of treatment, you can pull up these images and show them, okay, last week your baby looked like this, and this week your baby looks like this, and this is why we're thinking about treatment. And they can get a better understanding of what's happening and why it's so dangerous if we don't follow them closely, because of course nobody wants a baby to go blind. And because they get this understanding, they feel like they're an advocate for their vision, and truly they become lifelong advocates for their child's eye care, which is an amazing benefit. So if they feel like they're lifelong advocates for their child's eye health because they've been advocating for this since they were teeny tiny in the NICU, they're going to take them to their post-discharge appointments. So you're going to have increased compliance post-discharge. And this one is huge. This is something that the program that I led really prided itself on, in getting all those babies at 100% to comply with post-discharge appointments. It takes a lot of effort. It takes a lot of education. But the more understanding that those parents have of what's going on with their baby, the risks that are associated with ROP, it really gets them on board for following up and making it to those outpatient appointments. Again, because you can show them the weekly photo progressions, and they know that the ultimate goal is to have their baby, preserve their baby's vision, right? And that's what we want. And so it really helps them to make it to those post-discharge appointments, which are so important. Another patient benefit, if you have an RN screening program, is that it decreases your patient transfers. So families are able to stay together. The hospital that they delivered at, they can stay there. Oftentimes that hospital is nearby to their home. And so it, it allows for the family to be able to visit more often, which of course is going to promote breastfeeding, family bonding, more frequent family visits, and just family care involvement in every facet of this baby's care, which is what you'd like. It just keeps everyone happier. Okay, so then the next set of benefits that we're going to look at are benefits from the unit perspective. So here they are. So one of them is an increased environment of family-centered care, decreased missed patients, decreased patient transfers, decreased ophthalmology need to physically access the unit. The ophthalmologist is available to see more patients. Autonomy to continue to provide ROP care and maintain their accreditation status. increased communication within the healthcare team, and of course, seamless discharge. So let's look at each one of these. The first one, from a unit perspective, it's going to increase your environment of family-centered care. So the more family-centered that a unit can be, you're going to have patient satisfaction scores. That's what families want. They want to be comfortable in a situation where they feel like their baby is supported, that their family is supported, and that they matter. Right. And so if they feel happy with their care, they're going to increase their word of mouth referrals. And in turn, this is going to create much more local community support for your healthcare institution, which is wonderful. Right. And so if your families are happy and they're coming back and they're enjoying being there, you're going to have happier staff, which is going to also lead to higher staff recruitment and retainment, which is so important because you're going to have an overall positive workplace environment. The next benefit from a unit perspective is that you're going to have decreased missed patients. So missed patients are a huge source of litigation for facilities. These lead to massive lawsuits. So you're going to potentially alleviate these massive lawsuits for our missed ROP screening and potential blindness cases. And of course, if that's decreased, then you're going to increase your patient safety. Because the nurses on the unit are in control of scheduling the patients, they also know and understand when patients are moved to, like, let's say a step down unit, or if they're going to be moved to maybe a unit that is closer to home for them, they're going to ensure that the patients remain within the screening program until they are no longer at risk or fully vascularized as determined by the ophthalmologist. So you're not going to lose missed patients for this. And then also, they're going to ensure that proper follow-up is scheduled prior to that baby going home or being transferred out to a different unit. Also, they're going to make sure that your parents have a better understanding and that they're really going to know the importance, again, of not missing those outpatient appointments prior to discharge. So another huge benefit to the unit is that you're going to have decreased missed revenue opportunities from decreased patient transfers. So you're going to keep all those revenue from the admissions, less missed opportunity for admissions because you're going to have a program in which you can screen those patients and that it's not a problem. So they're not going to have to be admitted to a different unit. You can keep those patients in-house. And then you're going to have increased patient satisfaction because families are going to be able to stay together. They're not going to be separated by distance and have to travel to different units. And it's just going to provide an overall it's going to provide less disruption in the care of that patient. The next unit benefit is decreasing the ophthalmologist's need to physically access the unit. So because you're going to have an RN screening team to provide excellent and, of course, comfortable, or as comfortable as they can be, ROP screening exams, really the ophthalmologist doesn't need to come into the unit as frequently. Therefore, they can spend less time traveling because they can view exams remotely. They can spend more time in their clinics, and it really does less of a disruption to their clinic practice because they don't have to leave in the middle of the day to go and see their ROP babies and then come back to their clinic. They can sit at lunchtime and review all of the ROP exams and then make decisions from there. It's really a great benefit for the ophthalmologist and the unit as a whole. So to kind of piggyback off of that one, another unit benefit is that the ophthalmologist is able to see more patients. So they can spend more time in their clinic. They can spend more time in the OR or wherever they need to treat disease. They can spend more time focusing really on those high-risk patients, whether they're inpatient or outpatient, because again, if it's an inpatient exam and they need more close follow-up, those RN screeners are able to complete that close follow-up as needed by the ophthalmologist or from the ophthalmologist recommendations. So again, they can follow the disease trajectory more closely in those high-risk patients, and that's by doing multiple or more frequent exams if needed. Also, they can spend, because they're not having to be at the bedside doing all of these exams, they really have more time to educate their parents if their baby is critical and going down a disease progression where they might need treatment. They can really sit down with those families and give them more understanding of what's going on. And it's able to grow their practice. So they're able to screen truly at different locations very easily because they can remotely view those exams. So another unit benefit is the autonomy to continue to provide ROP care and maintain accreditation. So contracts with ophthalmologists can be sticky, right? Contracts with in any aspect of medical care can be sticky. Sometimes conflicts arise. Sometimes the ophthalmologist needs to retire. Sometimes he or she becomes sick and is unable to provide ROP care. The unit isn't limited or dependent upon those contracts as much because they're going to have their own imaging system. So much like having the icon, you're able to really take ownership and of the program, and you're able to continue to screen those babies, continue to provide adequate ROP care, which is going to prevent a lapse in care time. And you're going to decrease your legal potential for missed patients, which is huge, right? You're going to decrease the revenue opportunity for lost revenue opportunity, for patient transfers. And it's going to help you maintain your level 3 status, which units need to have in order to provide, they need to be able to provide ROP screening care in order to maintain that status. Another benefit, of course, is increased communication within the care team. Everyone is on the same page. Everyone is discussing about what needs to happen for this baby to go home. And that includes everyone on the RN screening team, the ophthalmologist, the neonatologist, the nurse practitioners, case managers, OT, PT, developmental specialists, any other specialists that are involved with the patient's care, and of course, the family. And if everyone is on the same page with the baby getting ready to go home, then you're going to have the end goal of a seamless discharge. Again, everyone's on the same page. Your family is prepared. They understand what's going on with their baby. They understand the disease process. And most importantly, they understand that there is a risk level of their baby going blind. And so they're going to make it to those follow-up appointments because they're going to understand what they need to do to preserve their baby's vision and prevent their baby from going blind. And also, when they have this understanding and they have this knowledge base and they have this confidence, they just are confident in caring for the infant at home. Taking home a NICU baby is different than taking home a term newborn. And so just preparing them, arming them with that knowledge base just gives them confidence in caring for their baby at home and doing the best that they can for them. And that's what we want. We always want our babies to have the best care possible, especially when they go home. Okay, so now that you kind of listened to so many of the benefits, I mean, I could just go on and on and on about the benefits, but so now what? So now you're ready to move on to the next step and you want to select and create a screening team. So one of the priority things that you need to ask yourself is who's going to oversee the schedule. So oftentimes this is someone who is an ROP coordinator or a program manager, and this is typically a registered nurse or an NMP. How many screeners do you need? Well, I recommend a minimum of 2, and then that way they can cover vacations or sick days or what have you. But this is totally unit dependent. If you're a high volume unit who is going to be screening a lot of patients, you're going to want more people. But again, you're not going to train all of your nurses. This is going to be a specialty group of nurses that will provide ROP screening for your patients. I do also recommend that it is someone who has some experience. So a minimum of 2 years of clinical experience at the NICU or in the clinic or at the bedside. So that way they're comfortable with how the clinic functions, the unit processes, and they're comfortable handling the patients. You don't want someone who's never touched a NICU baby before because it's going to be a lot. It's going to be intimidating for them. And so if it's someone who has had experience with this, you're going to have more success in the long run. Also, you want to select people who have a desire to learn a new skill set, right? You want someone who volunteers rather than being voluntold to do something. That's a huge, huge point. Also, you want someone who is a very clear and excellent communicator. You want someone who is going to be on top of things. You also want someone who's comfortable with the eye screening. Now, they may have never participated in doing ROP exams with a camera before, and that's okay. As long as it's someone who knows why the baby needs to be screened, is not squeamish about the eye, because that can be a big thing too, is ready to learn and is ready to jump in there and help and learn a new skill. They also need to be someone who is semi-comfortable with technology, right? Because it is technology that we're using to screen these babies, and technology does change and it is a little bit confusing at times. So if you have someone who really doesn't want anything to do with technology, that's probably not your best bet of someone that you want on this team. Someone who's more comfortable with it would be a benefit. Also, you want someone, especially for your ROP coordinator role, who is very highly organized, because you don't want any missed patients. Those schedules need to be complete, they need to be thorough, they need to be maintained, and they need to be checked often. Okay, so here's some next steps. What do you do to implement a new nurse-led ROP program? So we kind of talked about this a little bit. First, you're going to select an ROP coordinator, and this person should be organized, reliable, motivated, willing to learn, excited about this new program. And they should maintain and possess some leadership skills, because they're going to be kind of overseeing a lot of it and kind of helping with your team. So with your team, you want someone who is experienced. You're going to want a small team, but an appropriately sized team for your unit or your situation. So I recommend at least 2 people. These people should be organized, reliable, motivated, willing to learn, excited, again, just like the ROP coordinator, and they should like to work as a team. Okay, so now you've got your team, you've got your ROP coordinator, now what? So now you're going to establish your protocols and workflows. So you're going to create your policies and procedures and make sure those are approved. You can use wonderful tools like the CARES kit as a guide so that you're not starting from scratch. This provides a wonderful template that's best in its class for creating these protocols that you should be following, that and it's just meant to be used as a guide. You can absolutely edit it. You do not have to use it word for word, but it at least gives you a wonderful, very complete starting point. Then you're also going to need to understand, what are your ophthalmologist's preferences? So when does he or she want to read the exams? Does he or she want to do them at lunchtime? Do they want to do them first thing in the morning? Do they want to do them in the evening after they're done with all their clinic patients? Those are all things to consider, and what day of the week works best for them. Because often, or not often, I should say, sometimes the babies do need to be treated. And so this needs to be something that they need to consider in when do they want to read the exams and when will they have time to complete the treatment. And then how will images be transferred? So this is something that you can work with IT, and every unit is a little bit different of how those images will be transferred, how they will be read, so that everyone's on the same page. Okay, so now you've got your team, you've got your protocols, you're ready to move forward, you've got your device, you're going to train your team. You're going to train your team on the device, and this is going to help give them comfort before they actually lay the device on patients. So again, when you purchase a camera, you're going to receive the false baby head with the false eye. And the more practice that your team can do on this false baby head with the camera, the more comfortable they're going to be. And it's only going to add to their image quality in producing better exams in a more fast, quick fashion than someone who's never practiced before. And it's just going to set you up for better success long-term. Also, you need to establish what kind of continuing education or skills checkoff you're going to use. This is totally unit dependent, but this could be annually, it could be every 6 months, it could be every 2 years, whatever you think. And we're going to train the trainer. So we're going to train a handful of people, but then you also want those people to be able to train new employees if there's any staff turnover, or if someone just decides this isn't for them. That way they're competent and confident also in passing the skill along and training new ROP screeners. Okay, and then once you have all those pieces in place, you're going to roll it out. And when you roll it out, you're probably going to make some changes. So you're just going to have to evaluate and modify and make adjustments as needed after that initial rollout, and ensure that the entire care team who's involved on the unit understands this new process because, right, it's a change in your old process. And then just kind of make it to what you need it to be to fit your unit's needs. Okay, so you're off and running. So how are you going to evaluate your success? Well, I highly recommend, and especially at the very beginning, but really throughout the whole life of the program, you're going to have frequent observation and evaluation of missed patients. That's number one. You want to make sure that whatever you're doing to complete the schedule and to update that schedule, that it is working, that you're not missing any patients, because that is the huge piece of it, right? We don't want missed patients. And then also the quality of your imaging. Again, practice makes perfect. Get as much practice as you can with the baby doll, because honestly, some units might be smaller and they may not have patients to be screened every week. And so you don't want to lose those skills. So honestly, anytime you kind of think about it, if you're having kind of a slow day, get that baby doll head out and practice. Even if it's just for 10, 15, 20 minutes of practice here and there, that will help maintain your skills, maintain your image quality, and really take it to that next level. Also, it's wonderful if you can have support and feedback from your reading ophthalmologist. So that way he or she can voice with the team, and especially with the ROP coordinator that can kind of disseminate the information throughout to the team, what's most important in imaging, if images need to be lighter, if they need to be in better focus, or what the ophthalmologist specifically needs from those images to make them better and just make them of higher quality. Another thing that you're going to want to do is just continue the education for RN screeners so that they're aware of what they're doing, how they're doing it, why they need to do it, and then of course make adjustments in your workflow as needed. It's probably not going to be perfect the first time you roll it out, and you might be making changes for a little while, and that's okay. You can make it be whatever you need it to be, and that's so wonderful. What's so wonderful about it is that it's so flexible, and really the opportunities and the options for how it should be structured really are endless. So it's totally unit dependent, and make those adjustments as needed. So thank you so much for listening today to my webinar. I hope you were able to glean some information and about the benefits of a nurse-led ROP screening program. I hope you're excited about it and wanting to learn more. Just know that here with Neolite, we will support you every step of the way. We will hold your hand just like we're holding this baby's hand. We've got a passionate sales team. Our clinical care team is so knowledgeable. We've got excellent resources like the CARES Kit, which is there's nothing better out on the market. It really is such a fabulous, fabulous resource, and something I really wish I had when I was starting my program. So I hope that's something that's very beneficial to you. And then of course, our IT support is outstanding, as well as everyone that works for Neolite is really on the same page. And we are such an empathy-driven company and ready to be here to help you and your program's needs. So thank you again so much for listening. I hope you found it useful, and we hope to talk to you soon. Thanks so much.
Thank you, Edyta, so much. I'm going to go ahead and close this program out, and we are going to get cameras back on and open the floor for some questions. So let me see. Let's get this. Hi, everyone. So we are going to get Edyta's camera here on with us as well. We've had a couple questions posed through our Q&A platform. If you are on a device, it's going to be different for every device, iPads, phones, computers, but there should be a little question mark maybe at the bottom of your screen. And when you push that question mark, it should give you the ability to type in questions. We're going to get through as many of them as we can today. We've got 5 or 6 that it looks like we can answer. And then we will close out our session. So let me see here. Edyta, can you hear me? I know we've got her here in the background. So I'm going to we've got Ryan here with us today. I'm going to let him try and get Edyta.
Can you hear me now? Okay, I think it was just taking a while once it switched over. So.
At first it wanted to keep you on camera, and now it wants to keep you from camera. So, all right. So I do have a couple questions, Edyta, and I'll pose a few to you. I think there's a couple that I may be able to answer just in terms of billing. But I know one of the questions that we had come through based on your presentation is, are there certain credentials that are required for being a part of these imaging programs or ROP programs? So do you have to be an RN? Do you have to be an NNP? What did you see built with your facility?
So we used all nurses, and that's what worked for us, registered nurses. And so there are other programs out there in which the nurse practitioners do it, or the ophthalmologist does it. But for us, it worked best to have the nurses. You can also have an ophthalmology technician if you're in a clinic, just someone who's familiar with the patient and want to make sure that it's part of their scope of practice, right? So that's the most important part too, that you're not just having anyone come in and do it, but it should be a nurse or someone who is certified in caring for those patients.
Sure. And I agree with you. I think every program is built just a little bit differently. So my background's ophthalmology. I'm a technician that worked with a retina specialist, and I would go over every now and then and kind of help with that. So I think you're right in saying it's not a certain credential. It's just making sure that they're good with patient care and confident. We did have another question pop up, and I think you'll be able to help with this because you had a pretty high volume clinic. It says sometimes we have 6 or more infants to screen in a day. And how do you recommend spreading that out? So when you were looking at your imaging days, did you kind of set a plan for what that looked like and how quickly you thought you'd be running through your exams?
Yeah, so this is something that you'll adjust kind of as your program develops and as you get more experience, but kind of time, and it doesn't have to be, exact, but kind of understand the amount of time that it takes you to image one patient. And then that way you can kind of adjust your schedule. So maybe you can do 3 patients in an hour. Maybe you can do all 6 of them in an hour. And that way you can kind of understand how you're doing your drop schedule. And then again, adjusting with whatever that baby needs for that day. So maybe some need it in the morning, some need it a little bit later in the afternoon. So really it is just kind of dependent upon how quickly you can do them with your comfort level. Newer screeners are going to take a little bit longer, and that's okay. That's to be expected as they're building those skills and really establishing an understanding of how to screen the babies with the camera. So that's something that's flexible. So like I said, just kind of time yourself and gain an understanding of what works best for your situation. I mean, we did have days, we would cut it off usually. I think 12 was our maximum. Again, this was a very high level unit. So in each unit, we kind of would cut it off 12 to 15 and then spread it to maybe the next day because we did want to take our time and we didn't want to just run through all those babies. So again, that's very unit dependent. Mm-hmm.
I have a couple questions here that I think we could probably both answer. And you're going to hear us say this a lot, that it's unit dependent. So I know we had a question about billing. And one of the questions was, what parts can be dropped when you have an RN performing exams? So I know for myself and our unit, I live in Southern Missouri, we didn't actually bill for exams. They were just kind of covered. We didn't bill for them separately. But over so many years, I've kind of onboarded facilities throughout the world. And what we'll see are some units using modifiers on their codes. So a technical component and a professional component. And if you're wondering what your unit should do, more than likely, if you were imaging, you would charge for the professional component or the technical component. And then your reading physician can charge for the technical component. So you're splitting that code into 2 parts, who's doing the imaging and who's reading them. There are also codes that are pretty specific to telemedicine for retinal care. And in our CARES kit, we have a CPT code guide. Again, you're going to want to do your own due diligence, but it kind of leads you down to see what codes are available and what modifiers are available so that you can look and see what is best for your unit. Another question here is, what amount of time is required to clean the camera in between patients? And I know, Edyta, you guys had adjusted for that, and it's probably dependent on patients. I know we have some cleaning guidelines that we are happy to share, and they're leveled out because, like a broken record, every unit is different in how they reprocess and clean their systems. So again, that may be dependent on your processes specific to your system. Another question about the handpiece is, do we feel that a heavy camera can cause pain or damage to the eyes? So Edyta, that kind of goes back to your discussion about practicing, like getting comfortable with that muscle memory, right? And is that what your nurses did in your unit?
Absolutely. So the more you practice with it, you'll get kind of a sense for how you hold the camera. And once you start imaging on patients, if you're using too much pressure on the eye, you'll actually see the optic nerve pulsing, and you don't want that. That means you're using way too much pressure. So we always recommend using a gel, and that's just an extension of your camera lens. It kind of helps to soften the pressure that you need to use, and you kind of just establish a technique for how you hold the camera, whether you use a pinky to kind of, on the baby's forehead, or however you do it. But again, the more you practice on the false baby head, you'll have a better sense of how to hold that camera and how to very gently lay it on the patient's eye.
That's such good advice, because I feel like you have more opportunities to hold the camera and practice on your false baby head and figure out what your movements are. I have something called a fancy pinky, so I balance myself on their temple. And if anybody's ever trained with me, they've always heard me talk about my fancy pinky. But everyone's hands and muscle memory is different, especially if you're left-handed versus right-handed. So getting that out and really practicing in a clinical setting, like actually in a unit, in a radiant warmer, in a crib, however you would normally be imaging, practice like you play. And you're going to pick up on those muscle memories, which is just going to make you even better when we're actually imaging on live patients.
Absolutely. And Candace kind of mentioned this a little bit, but also putting your baby head in different types of beds that you have on your unit so that you can understand how that changes your arm position now, because maybe now you're in a bassinet, and maybe we learned that for us, the bassinets weren't fantastic. We would actually take the baby out and put them on a flatter surface, be that a scale or something else where they're safe, of course, but that it does create a little bit of difficulty with your elbow having to be up so high. So that's, again, something the more you practice with the false head before you get on a live patient, it's going to be better.
Right. It is so crazy. It's wonderful to hear the different ways that people onboard and work through their programs. Because like you're saying, I've been in units before where they have almost a designated room for eye exams. So rather than going to each bedside, they're bringing those few infants into their imaging room so that they can image, like you said, in a flatter surface. So there's really no right or wrong way. There are obviously some very specific things into imaging correctly, but the rest of those things get to be built on what's perfect for your infants, perfect for your unit. So many opportunities to make it the best that it can be. Another question that we had come through was, do you have any recommendations for imaging micro-preemies? So when we have real small infants coming through, are there any tips and tricks to imaging them the best that we can?
So I think the biggest tip that we can offer you, or that I can offer you, is to make sure you have the correct speculum size. So if you have really large speculums, it's going to be really difficult to image in a little tiny micropreemie eye. So it's nice to have at least 2, maybe 3 different sizes that you can kind of play with and see what works best for that patient. Because if you have a large speculum, that's going to inhibit your camera even being able to lay on the surface of the eye. So that's a big tip. Another tip would be just make sure they're positioned correctly. Use those extra set of hands. Maybe use OT or PT if they're available, a respiratory therapist if they're available, whoever you can get to help you just support that patient while you're imaging. And then again, the more you do it, the more comfortable you're going to be, and it'll flow more smoothly. But the speculums, I think, are the biggest tip.
Awesome. So we're almost to the top of the hour. I do have one question that I think I can answer here. It says, are there good videos on how to perform the eye exams with the camera? And we are in the process of trying to get some good videos put together. And there's a delicate balance, and I'm sure everyone knows, in terms of imaging or recording things in a unit, because we have to be very careful to make sure that parents have signed off. But we are working on producing some really great videos that allow people to see someone else being successful in a certain way. We do have a lot of education material, though, that is going to help you improve unit flows. So Edyta talked so much today about setting expectations, helping people say, do I need to review this information every 6 months, every year, every 2 years? We have skills checklists. We even have a goals document, because everyone may want to set different goals to say, I'm going to do 5 exams in a week. And if I only have 2 babies, that means I'm going to get the system out 3 times and just practice in the unit, so that I have 5 exams that have been done throughout the week. And you can set those goals and then follow up on them and kind of file that information away. So always check back in with us. We're going to continue to do e-seminars like this. We're going to continue to help improve processes within hospitals throughout the world. So without stopping to cover any more information, we'll let Edyta go. And I can't thank you guys enough for joining us today. If you have any more questions, don't hesitate to reach out.
Thank you so much.
Thank you.